Hello everyone, welcome to this video where we will be discussing the dermatology recall questions asked in the FMGE July 23 exam. As you all who have given the exam will agree that this was not an FMGE exam. It was almost similar to giving a NEET PG exam because the questions were quite high level. They were all concept based, clinically oriented questions. I sincerely hope that all of you have done the exam well, you will pass it, and I will see you on the other side. And for those who are still preparing, who are yet to give the exam, please be very thorough with what you are studying because there is no scope for rote learning here. You have to understand the subject, form your concepts, and practice the questions. For the dermatology part, like I say happily in every recall video, I'm very glad to say that all the questions that were asked in the exam were discussed either in the regular classes or the rapid revision classes, and there is nothing that I have not taught you. So for all my students there, I hope you did 10 on 10 in dermatology. Now, previous year's questions were asked in this exam as well. I can tell you that almost 100% of the questions are from the previous years. Yes, the language is slightly turned, twisted, maybe changed here and there, but the basic topics are the same. I will reiterate the importance of being very thorough with the previous year's papers before you go to give your next exam. Now, starting, this is not the NEXT, it's the lowercase next exam in December. So starting with question number 1 here, a 50-year-old male presented with skin lesions as seen in the image below. On examination, painful swollen fingers were noted along with an inflamed wrist joint. What is the most likely diagnosis? So here the question is telling us that the patient has skin involvement plus the fingers are swollen, the wrist is inflamed. That means there is a component of arthritis. So the patient here has skin plus joint involvement. Now let us look at the skin. On the skin there are red scaly patches as you can see here, and these have beautiful silvery white scaling on it. Along with that there are some changes in the nails also. So the patient has skin plus nail involvement and joint involvement. Let us look at the options: reactive arthritis, psoriatic arthritis, osteoarthritis and pseudogout. Pseudogout is joint involvement due to deposition of calcium pyrophosphate crystals. Here you see sudden inflammation in the joints, but you don't see any skin involvement. So this is not the answer here. Osteoarthritis, generally in the elderly, again with a different kind of involvement, no skin lesions. Now we have to choose between reactive and psoriatic arthritis. In reactive arthritis, there will be a history of a preceding infection, whether a gastric or a sexually transmitted infection. Plus, there will be a typical triad. The skin lesions are different. They are not these patches that you've seen in the image here. So this is also not the answer. What is the correct answer here? Correct answer is psoriatic arthritis. 1, you see the typical red scaly patches or psoriasis. 2, you see the typical arthritis here. Now, what is the typical arthritis in psoriasis? In psoriasis, this is a seronegative spondyloarthropathy. So this is a seronegative type of an arthritis with higher chances of having HLA-B27 positivity. In these patients, as the name suggests, there is an association of psoriasis with arthritis. 70% of the patients will have skin lesions before they have joint involvement. Another 20% will have skin and joint together. So 90% of the patients, which is like almost all the patients that you see, will have psoriasis on the skin with joint involvement. And how does psoriasis look like? These beautiful red scaly plaques on the body. The scaling being silvery white micaceous scaling. So when the question tells you that the patient is having typical psoriasis lesions, you should start thinking of psoriatic arthritis. When we talk about the joint inflammation, the most commonly involved joints are the distal interphalangeal joints. These are the most commonly involved joint. Now, when these joints are inflamed, the overlying skin also shows redness and swelling. Sometimes the entire finger becomes swollen, and these are called as dactylitis. This is called as dactylitis, which is inflammation of the fingers. And because it looks so broad and Like a sausage, it is also called as sausage digits. So when a question says sausage digits, it is telling you that the patient has dactylitis. Now, there is also wrist involvement. There can be ankle, knee joint, multiple joints can be involved in psoriatic arthritis. So when you have typical psoriasis with arthritis, the answer is this. In December 21 exam, they asked you a question that a patient with skin lesions as shown below presents with psoriatic arthritis. What is the drug of choice? There, this picture was given where there were red scaly lesions on the back. So when a patient is suffering from psoriasis with psoriatic arthritis, the drug of choice is methotrexate. So this question has already been asked in the FMGE exam 2 years back. Okay, so this is also a repeat question that they have asked you this time. Drug of choice for this patient is methotrexate. When you do an X-ray of the fingers, you see the middle phalanx has osteolysis here on the terminal end, which makes it look like a pen, and the distal phalanx shows concavity, which makes it look like a cup. So this is called as the pencil in cup deformity, which is a very typical feature of psoriatic arthritis, generally seen in the later stages of the disease. Now, when there is reactive arthritis, I just put it here to tell you the differences. In reactive arthritis, there will be a history of infection. Either it will be a history of dysentery, that is a GI infection, or there will be history of a non-gonococcal urethritis, which will be caused by chlamydia trachomatis D2K. Now, this kind of a patient around 1 month after the infection will come to you with a typical triad of conjunctivitis, urethritis, and arthritis. Here, the skin lesions will develop after the onset of the reactive arthritis. The patient will present with these typical scaly lesions on the palms and soles, which are called as keratoderma blenorrhegica, and these ring-shaped inflammatory lesions on the penis, which is called as circinate balanitis. So here the skin lesions are number one different. They are present only on the palms and soles and the glans penis, and they will occur along with the onset of arthritis. Plus other features of conjunctivitis, urethritis, and a previous infection will be given. So this is how you differentiate reactive arthritis from psoriatic arthritis. Coming to question number 2, trichotillomania is associated with trichophagia. In excessive conditions, it can lead to. So here the question is telling you that there is a condition called as trichotillomania, where the patient will pull out their own hair, and this is associated with trichophagia in some cases. Phagia means eating. So the patient is eating the hair that they are pulling out. So when you're eating the hair, can it be digested? No, it cannot be digested. So when you eat the hair, it is going to accumulate in the GIT. So when it accumulates, it forms a stone-like collection. This stone-like collection is called as trichobezoar. So the correct answer here in question number 2 is trichobezoar, which is a stone-like collection of the ingested hair in the intestine. Malnutrition, definitely if a patient is just eating hair and not eating food properly, there is a component of stress, a psychiatric disorder, it can lead to malnutrition, but the best answer is trichobezoar. Anagen effluvium and alopecia areata are completely different entities. They are nowhere associated even closely to this condition. Now, let us talk a little bit about trichotillomania. See, trichotillomania, alopecia areata, telogen effluvium, there is at least one question from the hair every year in the exam. So this is like a very important topic. Trichotillomania, tricho means hair, tillo means pulling, and mania means a psychiatric disorder. So here the patient is suffering from an obsessive compulsive disorder where they are pulling out their own hair. So when you're pulling out the own hair, will there be a typical patch on the hair? No, it will be just a bizarre shaped irregular lesion from hair the patient is pulling out their own hair. So bizarre and irregular margins is very classic of trichotillomania. Along with that, when you pull the hair, are you pulling it from just one point? No, you will pull it from different points. So here there will be broken hair of different lengths. And due to the trauma of the pulling out, there may be some bruises or hemorrhages around the hair, which is again a classic hint towards the diagnosis of TTM. And in these patients, since it is a psychiatric disorder, it can be associated with stress, anxiety. Here, the patient may end up eating their own hair once they pull it out. This is called as trichophagia, where the patient is eating the hair that they are pulling out. And as I already told you, they accumulate in the GIT in this kind of a stone-like collection, which may even take the shape of the intestine. This is called as trichobazoar. And such patients will present with symptoms of intestinal obstruction. This is a rare but an important cause of intestinal obstruction in such patients. Now, what is the treatment of choice for trichotillomania? Since it's a psychiatric disorder, treatment of choice is a psychiatric treatment, which is cognitive behavior therapy. However, if you have to give a medical treatment, in that case, the drug of choice are SSRIs, which like fluoxetine, paroxetine can be used in these patients. Now, coming to question number 3. A patient presents with itchy lesions and he applied steroids on it. What is the diagnosis? So when you think of itchy lesions, you can think of fungal infections. When you look at the image here, what do you see? You see that there is a mild ring shape here. In other areas, it is just an ill-defined patch. And on here, you see some red lesions, some hyperpigmentation, but there is no scaling, no vesicles, no pustules. So even though in some part I see like a feature of tinea, which is an annular itchy lesion, other times I can't diagnose it. So this is a lesion which is modified. It is not showing me typical lesions. Why? Because the patient is applying steroids on it. So can I call it tinea corporis or cruris? No, because I cannot identify the exact features of the disease. And since it is unidentified, it is called as tinea incognito. So the hints towards tinea are number 1, it is a red plaque. Number 2, it shows annular in some areas. And number 3, it is itchy. But since there are no typical features, it is incognito. That is why it is called as tinea incognito. Now look at the typical lesion here. If a patient is presenting with tinea, typically it will be a red ring-shaped plaque which will be expanding peripherally. Then there will be scaling vesicles and pustules. It will be intensely itchy, and then I can make a diagnosis of tinea corporis or cruris. But if the patient is applying steroids on it, steroids is an immunosuppressant, it will reduce the itching, the swelling, the scaling, everything will be reduced, and the redness will also be reduced. So here the lesion may show some component of tinea, like it may show a ring shape like you can see here, but not typical features on the surface. So this is a modified tinea. It is steroid modified tinea. That is why it is called as tinea incognito. And when you stop the steroid, all this inflammation will come back. So the question sometimes may say that the patient of tinea is applying an oral over-the-counter cream. On stopping the cream, the redness and the itching come back. What is the diagnosis? So wherever the question tells you that it is recurring on stopping the cream, the answer again is tinea incognito. In such patients, you have to stop the steroid cream, start antifungals, and they will become all right. Now coming to question number 4, identify the lesion. This question has been asked just innumerable times. STIs are a very, very important part of your preparation. Here in the perianal area, what do you see? You see multiple skin colored, 2 hyperpigmented raised lesions which have a rough verrucous surface, and some of them also have this kind of a pointed appearance. So when you see such kind of raised lesions with a pointed verrucous surface, the diagnosis is condyloma acuminata. Some of you may know it as warts. Okay, some of you may diagnose it as genital warts when you look at it. Condyloma acuminata is just another name for genital warts. So don't get confused. This is just another name for genital warts. In genital herpes, there will be fluid-filled grouped lesions on a red base, which will be painful. In condyloma later, there will be flat-topped lesions of secondary syphilis, and hemorrhoids will be smooth skin-colored bumps in the perianal area. So all of these are very different from how a wart looks like. That is why the correct answer here is option A, that is condyloma acuminata. Now A for A, condyloma acuminata is just another name for anogenital warts. Acuminata means pointed. So these warts have a slightly pointed tip. Caused by human papilloma virus type 6 most commonly. So the most common cause is HPV 6. Yes, 6 and 11 both can cause it, but this is the most common cause. And then 16 and 18 are the ones which have a high risk of malignancy when they are involved. Now, when you look at this picture, do you see the pointed edge? Yes, this is a typical feature of anogenital warts. On treatment, there is an immune response modifier that we use. It is called as imiquimod. It's a toll-like receptor 7 agonist. Helps the immune cells identify the virus and kill it. When the patient is pregnant, the treatment of choice for genital warts is cryotherapy. If cryotherapy is not in the option, the next best answer is TCA 70 to 90%. Now, about the other options, I've just put a picture here so that I can tell you. Condyloma lata, lata means flat topped. In English also it means flat topped. In Hindi also it means leta hua, means a flat lesion. This is generally seen in secondary syphilis. Generally, always seen in secondary syphilis. So here you have these flat topped greyish white smooth surface oozy plaques. So here the surface is completely smooth and it looks shiny because it is oozing serum. So this is very different from what you see in warts. Just the first word is the same, condyloma, but there it is condyloma acuminata, here it is condyloma lata. Then in the genital herpes, I already told you we have grouped vesicular lesions on a red base and these are very painful. Hemorrhoids will be skin colored bumps in the perianal area. Now coming to question number 5. Here a 3-year-old child presents with a generalized vesicular eruption all over the body involving the trunk. Brother also has similar rash. What is the diagnosis? So here most importantly the question is telling us that the patient has a vesicular rash. So when there is a vesicular rash plus there is a family history, that means it's a contagious disease. The siblings have it together. So it is a viral rash. Now the options varicella, rubella, measles, mumps. Measles will just show parotitis and a mild red rash on the body. There will be no vesicles here. Mumps, sorry. Then measles will show a raised red rash which will sometimes coalesce together to form blotches like this. But this will be a raised rash. So you'll have small papules here. You will not have vesicles. Rubella is also a flat rash. The only rash here is varicella, which will show fluid-filled vesicles. So the correct answer here is varicella. And varicella, as you know, has a secondary attack rate of 90%. So higher chance of family members, the brothers and the sisters and the friends having it together. So the presence of the brother having the similar rash could be seen in any of these. All of these are contagious, but the vesicles take you towards varicella. Now, varicella is caused by the varicella zoster virus. With an incubation period of 10 to 14 days, the patient will first have a low-grade fever and then they will have the rash on the body. Since the rash typically starts on the trunk, this is called as a centripetal rash. It first comes on the trunk and then it spreads to the entire body. So this is called as a centripetal rash. When you look at the lesions, you see that the macule, papule, vesicle, ulcer, scab, all of these are present at the same time in the patient. So this is called as a polymorphic rash or a pleomorphic rash. This is a typical finding of varicella. Again, this question has been asked in the last 3 years, the polymorphic rash image of varicella, and even this dewdrop on a rose petal has been asked. When you look at the vesicle on the red base, it looks like a dewdrop on a rose petal appearance. So varicella is also a repeat question. About the other rashes in rubella, again, these are all differentials of fever with rash. See, all of these viral infections are a differential of fever with rash, but it is the type of rash which tells you what it is. In varicella, it was fever with a vesicular rash. In rubella, you will have a reddish pink rash with fever on the patient. They may have associated pharyngitis, conjunctivitis also, but here it is this typical flat red rash on the body of the patient. In measles, again, there will be fever, there may be conjunctivitis, then there may be Koplik spots in the oral mucosa, which are small white spots. Along with this, there will be a rash on the body, but the rash here may have raised as well as flat part. So it's a maculopapular rash. There will be a macule as well as a papule. And in some areas, they may coalesce together to form the typical blotchy rash of measles. So in measles, it is typically a blotchy rash. In mumps, a flat, like a red rash on the body may be present, but the typical finding that you see on examination is this swollen parotid gland. There is parotitis in the patient. Now, if only fever with rash is present, vesicles are not mentioned in the exam, then how do you differentiate chickenpox from measles? In chickenpox, the rash will start on the trunk and then it will go to the rest of the body, and you will see vesicles in the rash and you will see a polymorphic or a pleomorphic rash. On the other hand, in measles, there may be a conjunctivitis, there may be a runny nose. Along with that, it will also show Koplik spots in the mucosa, as we see in the image here. These are small white spots in the mucosa. On the body, the rash will be blotchy. It will first appear on the forehead and then spread to the rest of the body. So in measles, the rash will first come on the face and the forehead and then spread to the entire body, and there are no vesicles in measles. Now coming to question number 6, a patient presents with a hypopigmented lesion with loss of sensation. What is the diagnosis? Hansen's, tuberculosis, pityriasis alba and pityriasis versicolor. When it is a hypopigmented rash with a loss of sensation, so wherever loss of sensation is mentioned, your answer is Hansen's disease. It may be hypopigmented, it may be erythematous, it may be skin colored, but where the loss of sensation is mentioned, your answer is leprosy, that is Hansen's disease. Tuberculosis does not show loss of sensation. Pityriasis alba and pityriasis versicolor will surely show hypopigmented lesions. There will be scaling, but there will be no anesthesia. There will be no loss of sensation in these two. So the correct answer to question 6 is Hansen's disease. See, this is how it looks like. It will be a typical hypopigmented lesion with loss of sensation, because the bacteria is living in the nerves. When the immune cells will come there, they'll form a granuloma. They will kill the nerve. So when the nerve is killed, it will kill the nerve. It will not take any sensation. So in leprosy, hypopigmented lesion with hypoesthesia is a cardinal feature. Along with this, you may also see nerve enlargement around the lesion. Now, coming to pityriasis alba and pityriasis versicolor, both of these will be hypopigmented scaly lesions, but in pityriasis alba, it will be on the face of a child. So here it will be on the face of a child as hypopigmented macules with fine scaling. In pityriasis versicolor, again these will be hypopigmented scaly macules, but they will be seen in teenagers or adults, because this happens only after puberty, and in these hypopigmented scaly macules will be present on the upper back and the upper chest. They will not have any lesional sensory loss. Now coming to question number 7. A patient with history of burn 3 years back now presents with a skin condition as shown below. What is the diagnosis? So in this patient here, you see that there is a burn scar and in center of the scar there is a ulcer which is maybe non-healing and it has exophytic granulation tissue. What is this called as? When it comes, it's a marginal ulcer, BCC, SCC, or a melanoma. No, this is classically a diagnosis of marginal ulcer, which is an ulcer developing in a scar. BCC is very different. SCC, marginal is actually a type of SCC. So the best answer here is marginal. Melanoma will be a black lesion. It will not develop in a scar or a burn. So this is also not the answer here. Now talking about marginal ulcer, this is a type of an SCC which develops in a scar. It could be scar due to any reason, but generally burns are the most common cause. Patient will come to you with a non-healing chronic ulcer. Sometimes it could be a depressed ulcer, other times there could be a fungating granulation tissue on the ulcer, but nevertheless around the lesion you will see a lot of scarring. So this is a marginal ulcer. Now, BCC can also present with an ulcer, but in BCC, this ulcer will have typical rolled up borders which are classic of BCC. And when you look at the edges will be undermined. So in BCC, the edges are undermined and the margins are typical rolled up. This is called as the rodent ulcer. This is a type of ulcerative BCC. Again, very different from what Marjolaine was showing. And here I will show you the typical lesion of BCC also. This is a pearly, shiny lesion with rolled up borders, telangiectasias, and this is how a classic BCC looks like. It has no pre-malignant lesion. There are no scars in which it is going to develop. Now, coming to question number 8, this is a query question. It probably was there or was not there. I hope you can tell me if it was there or not. Now, look at this lesion here. Identify the condition. What do you see? You see a dark blackish brown lesion with irregular asymmetric borders, and the color is different in different parts of the lesion. So what do we see here? This is a border which is uneven. Then the lesion is asymmetrical and it has variable colors in it. So this is how this lesion is looking. When you look at it, does it look like BCC? I just showed you how the BCC looks. No. Squamous cell carcinoma again would not look like this. Now we have to choose between melanoma and seborrheic keratosis. Both of these are dark lesions. But the uneven borders, the asymmetrical margins, all of this takes us towards the diagnosis of melanoma. Melanoma as an image-based question has been asked in the last 3 years. In fact, in the August 2020 exam it was asked, and maybe last year also it was asked. So marginal ulcer was a very favorite 2015 to 20s as an image-based question asked multiple times in the FMGE exam. Skin cancers of late have become their favorite. So you cannot not know these important skin malignancies. Look at melanoma here. How do you make a diagnosis of melanoma? We do the ABCDE of melanoma. We see A is for asymmetry. The lesion's margins become asymmetrical. They become uneven because these cancer cells are spreading. So it's asymmetrical, it's uneven. Then because of the different depth at which these cancer cells are present, there can be multiple colors in the lesions. The diameter will increase, there will be evolving changes happening in the lesion. All of this is the ABCDE of melanoma that you see. Now, melanoma spreads by the lymphatic route. The most common type in the world is the superficial spreading melanoma. In India, what we see most commonly is the acral lentiginous melanoma. The staging is done using the Breslau's criteria. In the Breslau's criteria, a good prognosis is when the depth of the lesion is less than 0.75 mm. That is a good prognosis. Melanoma will always be a black lesion. So it will show black color because it's a malignancy of melanocytes. So wherever you see this black color, you think of malignant melanoma. On the other hand, in seborrheic keratosis, these lesions are mostly brown. They are dry looking, they are lustreless. These are benign conditions that you see on the face of a lot of elderly around you because they generally happen due to cumulative sun exposure. They are not a malignancy, they are no risk on their own. But sometimes they can be a marker of an inside malignancy, that is gastric adenocarcinoma. In such patients, there can be a rapid and a sudden increase of seborrheic keratosis all over the body. This is called as the laser trillard sign, where a rapid increase in seborrheic keratosis over the body tells you that the patient may be suffering from a stomach cancer. Now, what are the other skin markers of stomach cancer? We have acanthosis nigricans and trypalms. So when you finishing with our discussion here, you'll see that all the questions here are repeats. Not exact, maybe related, but they are all PYQs. So please be very thorough with the PYQs. You can watch the PYQ videos, you can solve the questions. Be very thorough in your discussion with your faculty, amongst yourselves. Don't rote learn. For we are keenly awaiting the result. I hope you all who have given the exam pass, and all the best for the students who are appearing in the December exam as well. Thank you. Whatever doubts, you can put them in the comments.